Okay, so we will begin the meet. I'm handing over the mic to Kaushal and you can continue.
Yeah. So this is basically a very interactive session, specifically made like that. I mean, I always noted that whenever I've tried to give a lecture to any audience, non-medical audience, so I really don't know what they're looking for, and there is a lot of gap between what I am saying and what they want to know. And finally, in the questions, they bombard me with a lot of questions. So basically, also what happens is when I try to even explain important concepts, sometimes the listeners are not interested in that. So I just wanted to be a very informative talk, like a very interactive talk. So it's absolutely informal, and you can just ask me anything. Of course, the questions, and even if you want to ask me something other than the questions, you are free to ask me that. Okay. So I am very passionate about cardiology, and I am very passionate about what I do. My angioplasties, and I don't know what's happening to you. You're flickering.
Okay, I think the net again might be poor, but I can hear you. Let me shut down the video.
Yeah.
Yeah, okay.
Yeah. So basically, where was I? Yeah, so I'm very passionate about what I do, and sometimes I'm really aghast at what information is being spread by WhatsApp forwards and nowadays reels. So that's why I started making reels since a month, and I plan to my only purpose to make these reels was to dispel the commonly held myths, and which were not true. So this is like an extension of that, and I would like to, with this forum, and many more to come, I would like to answer the commonly held beliefs and question some of the traditional thinking, which is not right in the scientific age. So yeah, we can start with the questions, Dhaval.
Okay. Is there any choice you want to go by, or should I start from the first question itself?
Oh no, we can just start it. Let's keep it informal. Let's not make it like a
Dhaval,
regimented thing.
Yes, Pratiksha.
acha, I have an idea, Dhaval. Can I buzz in?
Yeah, yeah. Go ahead. Pratiksha seems to have dropped.
Yeah, her network was low, right? I think she'll
Okay,
join again.
instead of wasting time, can we shoot questions at least to begin with,
Yeah,
get the
please.
ball rolling?
Yeah, okay.
Yeah, please.
So I wanted to say, guys, what I wanted to say that those who are present, I think it will be difficult for Dr. Kaushal to remember who had asked which question. So if we go by each attendant, like Mr. Venkat is there, Amisha is there, Dr. Pooja, everyone, Jay, Nisha. If one of them, if one by one they ask their questions, then their questions also will be answered, and Dr. Kaushal will be able to do justice to all who are present. I feel.
Sure.
Is that
That's
fine,
fine.
Dhaval?
Yeah,
Yeah.
yeah, that should be okay, I think.
Yeah, fine. We can go that way. So, we,
Dr. Kaushal, that fine? Okay, so
Fine,
you
fine.
pick
Yeah.
who will ask which question. वो आप देख लीजिए.
No, whatever. Dhaval, you can coordinate.
Great.
No problem.
okay, yeah. So let us start with Mr. Venkat. I think he had posted a couple of questions. So,
Yeah,
Mr.
please.
can start.
Yeah, sure. So to begin with, Dr. Kaushal, at what age should one get a preliminary checkup for heart, what do you call health?
Yeah. So very interesting question. Although now I am seeing heart disease in very young age. Like in 20s and even in teens. Yeah. I've done angioplasty. My youngest angioplasty is 19 years old. But I have seen
Oh,
people do angioplasty even on 9-year-old, 8-year-old boys. Yeah. So there is no age which is really exempt. But practically speaking, if everything is fine, then I think 35 is the good age uh, at which we should get a total body checkup done, which should include a 2D echocardiography, a stress test, ECG, CBC, creatinine, kidney function test, HbA1c, 3 months glycosylated hemoglobin or 3 months sugar average, fasting blood sugar. This should be done at 35 and then it should be repeated every year. So that we do not forget to repeat these tests every year, I do these tests on my birthday, so that I get a report of health on my birthday, and I don't forget my birthdays, so I don't forget to get this test done. So I think that should be done every year. Everybody should do it, and knowledge is power, and without data we can't act on anything, right? It's important because the traditional notions that you have to be fat to be diabetic, or you have to be fat or unhealthy to have blood pressure are obsolete. I have seen extremely thin, extremely fit individuals have blood pressure, diabetes, and so on and so forth. So yeah, I think there is no uh, uh, alternative to getting tested, and not once in a lifetime, every year, and if at all
What about
necessary, more often. Like for example, if your cholesterol is high and you start medicines for your cholesterol, then every 3 months, then after 3 months, you should see whether your cholesterol is normal.
what about homocysteine test?
So homocysteine, yeah, there was a question of homocysteine. Now, homocysteine is a very weird test, like in the sense that homocysteine is not directly related to coronary artery disease that strongly. It is more strongly related with pulmonary embolism, that is clot, which happens in the lower limb blood vessels and goes to the lungs, and that can be very severe. And homocysteine is common in Indians, especially vegetarians, because hyperhomocysteinemia is seen in patients who do not have uh, any vegetarian diet, especially vegans, unless they take B12 supplements, because B12 and folic acid are required. Especially B12 is required for decreasing the serum homocysteine levels in the body.
Oh, that's good. He's warning me.
Hyperhomocysteinemia, where the homocysteine level is more than 30, is considered a risk factor. But yeah.
Yeah, because I'm a vegan, so it's good that you told me that I need to I'm supplementing myself with folic acid and B12.
Yeah, you should. And you should measure that.
Good. Uh,
Yeah,
the next question was, okay, if there any order somebody has to take a next question, it's fine. Otherwise, I can continue with one or two more questions.
please continue. I was just going to ask you whether you want to have any further questions. So please continue.
Yeah. The next question is, what about what do you call CT angio? When is it done, and is it a foolproof test to know about blockages?
Nothing is foolproof, Mr. Venkat. But anyway, let me see what is CT coronary angiography. CT coronary angiography is nothing but a CT scan which is taken. There are like 128 CT. It started with 64 slice CT, then it went to 128 slice CT, then it went to 256 slice CT. So most of the hospitals and clinics nowadays do 128, 256 slice CT. There are some, very few who are doing 512 slice CT. Okay. So that is the number of slices are the number of slices which are taken per second, and more the number of slices per second, better is the resolution, which is known as temporal resolution. Resolution with respect to time. Okay. So CT scan basically shows you the blockages of the heart. There are two tests which are done in a CT scan. Whenever we talk about CT scan of the heart, one is CT calcium score, and another is CT coronary angiography. Now, I think whenever you are going for a CT scan, you should go for a CT coronary angiography only. CT calcium score will give you a score like 100 or 0 to 100, 100 to 200, 200 to 400, more than 400. There is a risk like this. Uh, There's a risk stratification like this, but it is not like I have seen patients with 0 calcium score having block in all the arteries, and I have seen patients with 400 calcium score having a completely normal arteries. So I would say calcium score itself is not predictive. Calcium score is more of a surrogate marker like lipid profile or cigarette smoking. So cigarette smoking will predispose you to heart disease, but does not mean if you're smoking, you'll 100% get heart disease, or vice versa. If not smoking, you won't get heart disease. No. CT coronary angiography is something which is more specific. But because we are not having higher slice CTs now, we are only able to slice the heart like 256 or 512 at the most times a second. We will still have motion artifacts because heart is a structure which is continuously contracting 70 times a minute. So sometimes some of the cuts, like CT scan, basically what happens is you pass the X-ray and other side of the CT machine captures the X-ray, right? But if the and then you take a series of 256 slices and then you construct it into an image. Okay. And that's how you see whether the coronary arteries, how the coronary arteries lie. And this is done by the computer using AI. Okay. They just 3D reconstruction, which is seen, is nothing but AI. And so there is a lot of aliasing known as guesswork in simple terms. The computer guesses what is the position of the artery in between two beats. So theoretically, more cuts we have, more precise information we'll have. Right now, we are having some centers 64, some centers 128, some centers 256 slice, which is still woefully incorrect. Now, the corollary of that is that CT will give you a rough idea of whether there is blockage or not. Okay. And if the CT is negative, then there's a very good chance you have nothing. If the CT is normal, absolutely normal, no block, then it means nothing that you don't have a block. That chance is 97%. But if the CT is not normal, if the CT is showing say 50% disease, you may have a 90% disease in the artery. So normally anything less than 75, we don't do angioplasty, right? But in a CT scan, you cannot be sure. In CT scan, you have 30-40% disease, it may be 70%, 80%. Because the computer guesses the position of the artery between the beats. And we don't have enough slices of the heart with the prevailing technology. So that is the thing. I'm sure in not so distant future, CTs will be much more accurate. But nowadays, so CTs are a good screening tool. Like for example, if you have a 60-year-old guy and he wants to start exercising, he says, I want to run the marathon. Now, running the marathon is not a good idea at any age, but that is besides the point. I'm just saying he wants to get physically active. He wants to go run on the treadmill, whatever. He wants to climb Mount Everest, whatever. So he says, just give me a certificate, doctor, whether I'm fit or not. So whether you have heart disease or not. So if you do a CT coronary angiography and the CT coronary angiography shows no disease, then you can just, with 97% certainty say that he has a good chance that he will completely normal. So he can do whatever he wants. On the other hand, if he has 50% disease on CT, we are not sure. Okay. In that case, if he has symptoms or if the doctor feels so, he should undergo a conventional coronary angiography in the cath lab, and that will give you a 100% result. So CT coronary angiography is a good screening test, but it is a bad confirmatory test. Okay. It has a high negative predictive value. That is, a test which is negative has high likelihood of being true, but it has a very poor positive predictive value. That is, a test which is positive may or may not be true.
So right now, angiography is the best suited
It's
to
a
know
gold
about
standard.
It's the gold standard.
Angiography is the gold standard.
Right. What about EECP treatment for minor blockages?
So EECP is a treatment where you basically put the patient on ECG put him on a table, and then the four limbs are fitted with four kind of plastic contraptions which contract and which inflate and deflate in rhythm with the heart cycle. Okay. Have you seen a ECP ever work?
Yes,
Yeah.
I've seen
So
it working.
basically, it's like blood pressure curves, but bigger on all four limbs, and they inflate and deflate. Okay. Now the thing is, this therapy was sanctioned in US in 1970 when nothing else was there, and it is still considered to be a therapy when you can absolutely not do angioplasty or bypass surgery. Okay. But if you can do either of them, ECP should not be done. Okay. ECP has questionable, if any, benefits. It is not a replacement for bypass surgery or angioplasty. It can be done in patients who either refuse both modalities of treatment or are not fit for both modalities of treatment.
Right.
So I have not recommended, to put it in perspective, I have not recommended any EECP in my entire career of 20 years.
Right.
So that is my level of confidence in the modality.
You might have heard about Dr. B.G. Hegde, a cardiologist who's also awarded with Padma Bhushan, I believe. There are a lot of videos on YouTube about his talks. So, in one of his talks, I heard that the heart also develops naturally corollaries to the collateral. Sorry. So,
yeah. So there is a hypothesis that ECP can make you develop collaterals, but collaterals is not the way to go. Okay. Now let me put it very simply. Okay. So area of a heart has no blood supply. Okay. Say left side of the heart has no blood supply.
right.
Okay. And it borrows blood from the right side of the heart. That is collaterals. The right coronary artery gives collaterals to the LAD. It gives small branches which supply the left side, right? Okay. Now, what happens? I will compare it to a very simple scenario which a common person can understand. For example, if there is a family and one of the brother loses his job, okay, now he borrows money from the other brother to run his family, right? Now, technically, theoretically, the family will run, but is it a sustainable alternative? Is it a sustainable option? Because finally, if the other brother has increased expenses or more financial need, in that case, he will not give blood to, he will not give money to his brother. If any financial calamity happens to the brother, the other brother will also be jeopardized. Both brothers will be equally jeopardized, right? And also, if the brother, now this brother, the poor brother, if his wife wants to say, I want to buy an iPhone, the other brother says that no, you first earn money, then you buy iPhone. I'm not going to give you money for luxuries. So it's similar in the heart. Okay. Corollaries are a very, very poor substitute. They can sustain life, but just about. When you start walking with coronary collaterals, you may have angina, chest pain. And if there is a blockage in the donor artery, which is supplying collaterals, you may have a massive infarction, massive heart attack, which may kill the patient on spot. So coronary collaterals are not the way to go. Coronary collaterals are a stopgap method to sustain life, but finally, the main purpose is to open the arteries and restore supply to both the vascular beds. It's like the solution is not that the rich brother donates to the poor brother. The poor brother also should go and find a job.
True. Very, very well explained.
And I mean, I don't want to name any doctor, like whatever name you named. I don't want to name any doctor, but some of the doctors on YouTube, on Instagram, those who are influencers, are explaining a lot of old theories which are no longer in practice, and their
Right.
thoughts are outdated, and they're not outdated by like a few years, they're outdated by like few decades. So in fact, tomorrow I'm making a reel on that very subject. Please, all of you, please see the reel, and it would be very helpful to understand, to put things in perspective.
Okay. Just one more question before I pass on. uh, a medicated, what is the difference between having a medicated stent and a non-medicated stent?
So last 20 years, the drug-eluting stents have completely dominated the market. Today, the scene is such that in Mumbai, even if I want to put a non-medicated stent, it's not available anywhere. There are no non-medicated stents put in the last 5 years in Mumbai. In fact, in India, all the stents are medicated. The medicated stents are basically, stent is impregnated with a medicine which is a anti-cancer medicine. Okay, and this prevents cell division. Okay, cancer basically is cell division, so this prevents
Sure.
cell division, because what happens is when you are doing angioplasty and inflating the balloon inside the artery, what you do in the angioplasty is basically you insert a wire inside the artery where there is a blockage, then you open that blockage by inflating a balloon there. So the plaque gets redistributed in the walls of the artery. The plaque, the blockage gets redistributed. It's like, when you play with plasticine, if there is, like, you press it on one side, it will come out on the other side, right? Similarly, the wall of the artery, it absorbs the plaque, right? Now, because when you press against the wall of the arteries with the balloon, there is some micro trauma. Okay. And because of this micro trauma, it's like a healing mechanism. Like if you have a wound on your hand, there is a scab formed, right? And there is uh, a plug formed with a scab, right? And platelets and other blood particles go there. They form a fibrin meshwork, in which platelets get entangled, and basically the wound is closed. They try to do a similar repair job inside the artery, but inside the artery it's much more dangerous, because if the repair job goes awry, then the whole artery closes down. So what this drug does is it prevents the multiplication of cells inside the stent so that the stent remains pristine. This is the current generation of drug-eluting stents, which is the third generation drug-eluting stents, have become extremely safe, and they are on a cobalt chromium platform, which is the most inert platform inside the human body. It does not invoke any reaction from the human tissues, and with that, and with the uh, drug-eluting stents, uh, it's like the reblockage rate is as less as 1 to 5%, 1 to 3% or something. And this 1 to 3% is for life. So the chances of a good angioplasty failing is like around 1% in 100. And that too can be decreased if you take good quality of lipid lowering agents, and take the medicines regularly, do lifestyle modifications, exercise regularly, eat right.
Thank you, Kaushal. Thank you so much. Let someone else also ask questions.
Yeah.
Dhaval, sorry to interrupt. Mahesh wants to enter the meeting. He said he is unable to enter. He has put it in the chat group.
But I have not kept any room also. Like directly people can join in. So in fact, I don't even have to approve.
Okay. Okay.
Someone has, in fact, just last someone has logged in. This 4FQQY something.
Yes, I have just logged in. Sorry, I'm late, but I did not have any waiting room issues.
Yeah, that's what it's. I have not kept that option so that people can freely log in.
Okay. Okay.
Pratiksha, you want to take a photo, screenshot or something? It's
I won't be able to from my mobile, but if anyone can, for 2 minutes, if we can all put our cameras on, then from somebody's mobile or laptop, we can take a screenshot.
yeah.
And I must really compliment Mr. Venkat also for asking such lovely questions. I think we all have got a lot of insight from Dr. Kaushal on this. So thanks, Venkatji, for asking these questions. Yeah. And so, Dhaval, shall I ask everyone to put their cameras on?
Yeah, let's do that.
I can't come on. I really cannot. But everyone just put their cameras on so we can take a quick photograph.
Okay, I am just taking one on my laptop.
Yeah. Ami, and who is 4FQQYW? I don't know. Ami, Jay, Nisha. Okay. Whoever is taking the photo, tell everyone to smile, huh? Because we don't know when to put that cheesy face.
Ami is watching a movie.
Easy.
Chalega. So people are joining from so many places. You know, Nisha, Jay, if you can put your cameras on. And there's someone at the bottom, Pooja Joshi. Dr. Pooja?
I am also
Someone at the bottom.
okay.
हमेशा एकदम ऐसे वो देख अमी मूवी देख रही है दूसरी हमेशा ऐसे मूड में जैसे वो गजल सुन रहे हो ना अभी एकदम
अरे मैं मूवी नहीं देख रही हूँ, I'm in an auto, darling.
अच्छा
Ah.
Yeah, it's okay if you have network issues, Dr. Pooja, but if you can just put the camera on for 2 minutes, like I'll put my camera on तो photo ले नहीं पाओगे आप लोग.
I need
So,
to
yeah.
get out of the train. अभी कितना time लगेगा और?
ठीक है, I think we just take the photo. I mean, time तो जिसके जितने questions है उसके ऊपर है. That's why he has said कि he'll answer only 6 questions. And we actually do not want to go beyond 2 sessions. After that, we can definitely, next session we can take. Yeah. So who's taking the photograph? Who's clicking the screen?
I am also taking, but someone else can also, just try.
Bindu is also, Dr. Bindu is also taking. Okay, great.
Yeah,
So everyone, cheese.
Yeah, cheese.
So I'm not telling some jokes. It's not a stand-up show.
No, but we like to have some humor in between, you know. It's serious
Okay.
topic. See, laughter is the best medicine, right? So,
Yeah.
Okay.
On demand of our organ, like आज के जो हमारे वो हैं डॉक्टर कौशल उनके कहने पर हम लोग
Yeah. Hi.
straight face वाला पिक लेते हैं, no smile.
Yeah, like एकदम शशि थरूर वाला, no smile.
Acha, okay.
We all
Dr.
are
Bindu.
now, we all are buddhas and worried about our heart. So, all
Yeah.
sad.
All in a grim, please show some grim face.
I think Venkat ji is the most grim. He has the most grim face right now. But Venkat ji, for the first time you've come for a Zoom talk, and let me tell you, Zoom talk was supposed to be done so that all the people outside Mumbai could join us. So very happy to have you here. And I would like everyone who's come for a talk over here to come forth and give talks on your topics also. So yeah. I'm done talking. Dhaval, please go ahead.
Yeah, thank you, Pratiksha, and thank you, Mr. Venkat, for asking some very interesting questions. So just to remind you, we are going to get logged out in about 2-3 minutes. So once we log out, I will save the recording, and then again I will resume the room, and you can all join in again. So next, Pooja, would you like to ask any questions?
I just have
so,
one question. Can I just interrupt?
Yeah, sure,
Yeah,
Amit.
please.
Yeah, Dr. Kaushal, you said you will not suggest anyone to run marathon. Did I hear that correctly?
Yeah, absolutely.
Yeah, but any reason for that?
Yeah, it's a rather long question. You want me to answer now? Because if there are other questions, I'll answer that before, and then I'll answer that question.
Sure.
Yeah.
So
You'll get interrupted in 3 minutes. I can't answer that question.
yes, correct.
okay, so can I ask my question?
Yeah, who is this?
Pooja.
Pooja.
Yeah, ask me, please.
Okay.
Pooja.
So we all know that heart disease is more common in men than women, except when we hit menopause, when women hit menopause, because estrogen is said to have protective effect on the heart.
Yeah.
Now, I wanted to you to throw some light on hormone replacement therapy that some women
Yeah.
are taking, and your
Yeah.
experience with hormone replacement therapy. I mean, the pros and cons of it.
Yeah. So cardiology circles are very clear about this. For no cardiological indication is hormone replacement therapy indicated. Okay. Now,
Okay.
estrogen is protective, but there's a big difference between endogenous estrogen and exogenous estrogen. Endogenous
Okay.
estrogen is what you prepare in your own body. Exogenous
Okay.
estrogen is what you take in a pill.
Correct.
Endogenous estrogen is protective from heart disease. Exogenous estrogen is not protective from heart disease. In fact, it causes thrombophilia, that it causes blood clots to happen.
Okay.
It's not
Okay.
unusual to cover. In fact, I had an article published in Times of India just last month, a month or
Okay.
two back, where a 27-year-old girl developed a heart attack in whom I did angioplasty. And
Mm.
she was like 1 week after her marriage because she took OC pills to postpone her periods, which were coming with
Mm.
like there is a Indian custom that, you don't want
Correct.
the periods
Correct.
during the marriage. So
Mm-hmm.
that is so exogenous estrogen is not protective. So hormone replacement therapy for obstetric indications, you may give it. That is obstetrician's call. But for cardiological indications, HRT is